सर ये क्या बात है, सारे न्यूक्लियर मेडिसिन वाले इतने जवान कैसे दिखते हैं? मतलब ये क्या डॉक्टर अभिषेक, इज देयर अ थिंग दैट वी मिस?
देखिए डॉक्टर अभिषेक को इसका राज मालूम है शायद।
अच्छा,
डॉक्टर अभिषेक तो का हम लोग 50 क्रॉस करके आगे बढ़ते हैं, डॉक्टर अभिषेक 30 की तरफ जा रहे हैं। ये एक मतलब मिस्टीरियस फिनोमिनन है। मैं खुद भी जानना चाहता हूँ कि डॉक्टर अभिषेक ऐसा कैसे हो रहे हैं। वो बताते ही नहीं है अपने सीक्रेट,
बताते नहीं है ना। आप म्यूटेड हो डॉक्टर अभिषेक, इसका मतलब ये नहीं कि आप बोल नहीं सकते।
सबका मालिक एक।
हमें ऑन्कोलॉजी में तो पता था, न्यूक्लियर मेडिसिन में कोई और है क्या वो सबका मालिक एक? ठीक है।
डॉक्टर शुभम, आप टाटा में थे पहले, टीएमएच में?
हाँ सर, मैं टाटा में था। आई वाज देयर फ्रॉम 12 to 15, 16.
ओके,
my
ग्रेट।
MCH there.
ओह ग्रेट, अच्छा।
बट आप थे सर तब, मतलब सॉरी।
हाँ, मैं 2003 से हूँ।
हाँ
तो मैं
हमारा पाला नहीं पड़ा।
नियरली 20 years हो गए।
हाँ, नहीं तो हमारी सारी डेट्स जल्दी हो जाती है अगर डॉक्टर अभिषेक हमें पहले मिलवा देते तो।
हम लोग तो वैसे भी आपका मतलब इन जनरल हेड अलग अलग सर्जरी यूनिट में रहते होंगे ना?
So we rotate
right,
through all of them, ठीक है ना? So we
हाँ,
rotate through all of them.
Right.
ऐसे करके होता है।
But as a rule, Dr. Shubham generally doesn't stick to one DMG. He generally encompasses everything.
So that is how the training is.
He just spilled the beans. He spilled the secret.
No, that is, it's no secret only, and we are live on YouTube. Let's start the class, sir. Let me introduce you and the topic, and we'll start the class. Dr. Geeta, you are in. Hi, I can see you. Acha, muted and.
Hi, I'm here.
Yeah, great. So we'll start. Okay. So I'll just start the recording. Okay. Hi. Good evening, and it's Wednesday, 8:30 p.m. and it's our Cancer Academy time, and we are continuing with the thyroid saga this month. And as we have gone through the previous lectures about pathology, about the different types of surgery, and this is one of those type of cancers which actually do not have much for the medical oncologist, and to some extent radiation oncologist, although my colleagues would differ on that. But we have something special for today, where we actually get in a previously unnoticed branch, which is now there for everybody to notice and to sit up and recognize with the advent of FDG. I'm sure FDG has now changed the textbooks for nuclear medicine, but we will go back to the original nuclear medicine, which was radioactive iodine, and discuss about its therapeutic and diagnostic implications in thyroid cancer. And we have with us a great speaker and a great moderator. I'll introduce the moderator and leave the speaker for the moderator to introduce. So the moderator is Dr. Abhishek Gupta. So yes, he is the younger looking with a lot of hair still there on your screen. And to tell you about Dr. Abhishek is that he is one of the youngest looking oldest person around, and we are very fortunate to have interacted with him. We have the pleasure of taking cognizance of his clinical knowledge, and we rely on his expertise in a lot of our nuclear medicine dilemma, especially with the PET nowadays. And he took it upon himself to get us a perfect speaker for this topic to speak on. Dr. Abhishek has taken this very topic for us within our internal lectures, but for this being a little different platform, we asked him to get us a different speaker, not because of the enormity of the platform, but just for the reason that we didn't want to hear Dr. Abhishek speak again. but I'll get Dr. Abhishek to please introduce Dr. Gaurav. Dr. Abhishek.
Thank you, Dr. Shubham. So, I would like to welcome Dr. Gaurav Malhotra. So, he's a professor in Radiation Medicine Center, part of BARC Mumbai. And he has been, so I've been knowing him since 1999. He has been my senior from Army Hospital R&R and then also from HCPGI. And we have interacted a lot. So I can very safely say he's one of the top three speakers on nuclear thyroidology in India, at least. Where he's got a vast expertise and really good experience in treating thyroid cancer patients. He's also a section editor of endocrinology in medicine journals by Walter and Kluwer. And he is also a member of the editorial board of Clinical Nuclear Medicine USA. And his main field of interest is nuclear thyroidology, PET imaging, and then targeted therapies. So, Dr. Gaurav, it's all yours now. Please enlighten us.
Thank you, Dr. Abhishek. At the outset, I would like to thank. Am I audible?
Yes, yes, you are audible.
Yeah. At the outset, I would like to thank all the organizers and especially Dr. Abhishek for bestowing faith upon me for this presentation on thyroid. Whenever there is anything to do with thyroid, I'll wrap it up. And I've been doing this with research papers, but research papers besides, I wanted to take up this topic in a manner, so that what we are doing practically day in and day out, that kind of a thing, the audience gets that kind of view about it. So I think I should begin the lecture.
Yes,
without right? So, for the screen, I will have to.
You can share your screen like you did before, sir.
Okay. Share screen. Okay, right. So here it is. Yeah. You can see my screen, right? Okay.
Yes.
Okay. So there are no disclosures, and the topic that Dr. Abhishek told me was about that to provide a bird's eye view of nuclear medicine in thyroid cancers. And the purpose of this presentation is to introduce the audience to what a brief introduction on what nuclear medicine or what functional imaging concept is. Then thereafter I'll be talking about radioisotopes in thyroid imaging and the technetium 99M, iodine 31 scans, etc. And this will be followed by the basic concepts of radioiodine therapy with relevant clinical examples and literature update. Now, and last of all, I'll be winding up with decision making and prognostication in thyroid cancers vis-a-vis use of radioiodine and newer therapies. I'll not be touching much therapeutic aspects except for the iodine, and restrict myself to iodine most of the time. And I will not be touching upon non-differentiated thyroid cancers. There will be the medullary thyroid cancers, etc. I will not be covering in this lecture. Now, first of all, coming to what is nuclear medicine. And, nuclear medicine is a specialty which uses radioisotopes or open sources of radioactive in safe, painless, and cost-effective techniques, both to image the body and treat the disease. Now, it is unique. It is unique because it tells about the function or documentation of organ function. And most of the time, the disease dysfunction precedes the structural alteration. So many a times we would find that there is aberration of the functional information, yet the structure is more or less normal. That is why it helps in early diagnosis of disease, and it helps in treatment and to some extent prevention as well. Now, what we do in nuclear medicine is we inject very small amount of radioactive materials, or what are known as radiopharmaceuticals. That are attracted to particular organs, bones, or and tissues. And when these are introduced into the body, they release radioactive emission. So what we are what we are practically doing is we are studying the body functions by these radio tracers. And how does this modality work? By chalking out the distribution of the radioactive compounds, which we image with some form of a detector, we are able to tell the functions. So the essential idea is that the radioactive substance acts as a tracer for a particular physiologic process. So if you are given DTPA, you can trace the renal function. If you are given maybe you can trace the cardiac function, and so on. No, so basically it's unlike radiology, it's an emission measurement, while radiology is transmission measurements. And to image these, we have special equipment. These are older gamma cameras, these are newer gamma cameras, and the SPEC systems, dual-headed gamma cameras. And so although nuclear medicine is commonly used for diagnostic purposes, it provides valuable therapeutic applications and as such as treatment of thyroid-related disease, including cancers, and pain relief from certain types of bone cancers, as well as receptor-based targeted therapies. What have been called as magic bullets. And origin was from many scientific discoveries like X-rays. They were discovered way back in 1895, finally leading to artificial radioactivity and so on. But the landmark event was in 1946 when a thyroid cancer patient was treated with radioiodine, leading to complete disappearance of the spread of patient's cancer. This is by the virtue of property of the thyroid cancer cells to express sodium iodide sympater, and so they are able to take up radioiodine, and radioiodine is expressed in the primary, is expressed in the metastatic as well as whatever residual primary remains after the surgery. I will be coming to that later. Now, so it is nuclear medicine uses ionizing radiation, radiology uses X-rays. This is whole body radiation happens in nuclear medicine, while in radiology, it is only the targeted interested area on which a particular area for which the radiology has been done. There is no accumulation as such. There is accumulation in radiology. We study the function. Well, then there's much less radiation as compared to radiology, which studies the anatomy. But are we competitive? Like, just look at this. This is brain anatomy, and this is the physiology. So, are we? Is there a competition out here, or are we complementary? The fact is that that now this is the first PET system. We are a complementary modality. There is a amalgam of PET and CT, SPECT and CT, and now PET and MRI. Where there is what is known as emission and X-ray CT data match, as a result of which we are able to get both the information, the anatomical and functional information in the single imaging. This is our newer camera system, that is the PET CT, state-of-art time-of-flight PET CT in our department. But what does it exactly do? Nuclear medicine is a functional imaging. It will provide information on function. So you would know that there is a hot area, what we define in our parlance as hot area or area of increased tracer uptake. And on structurally, it will look like there is some problem out here. But when we fuse, it is always additional information that we get, that when these images are superimposed, that we know where this exact hot area is, where is the biological impairment taking place. So even if the tumor has to be targeted, we know where is the viable zone from which the tumor should be targeted. And that is the beauty of these combined imaging or PET CT or SPECT CT for that matter. Among the diagnostic imaging procedure, the nuclear medicine procedure are the safest methods. Since patient receives very small amount of radiopharmaceutical just to get sufficient information. So coming to the thyroid, everyone knows about this, that the gland which is shield shaped, derived from word thyroid, and placed anteriorly in the neck. And as you see, it is made up of follicles, which are the function units, and where follicles, there are follicular cells, colloids, and it is basically the each cell, they produce various hormones, T4, T3, and most of the time T3 is converted in periphery. T4 is converted to T3 in periphery, and T3 is the active hormone, and it works on the principle of negative feedback mechanism. So as T4 and T3 increase, they will suppress the TSH, and what is known as feedback inhibition. When or alternatively, there can be feedback stimulation. Now, what diagnostic role is there in pre and post operative scans and in vitro test, hormone assays, and apart from that, there is also a therapeutic role. What are the types of scans in thyroidology? We use morphologic scans such as technetium per technetate to assess size, shape, and nature of nodule. Metabolic scans, that is radioiodine scan, I131, I123, SPECT CT, FDG PET scans. And then there are receptor-specific scans like iodine, MIBG scans, etc. And certain non-specific scans that have been used for years together, like thallium, pentavalent DMSA, or system AB. They do have some role to play in scenarios where other scans may not be helping. But coming to the most commonly used tracer, that is technetium 99M per technetate, which is the workhorse of nuclear medicine. It is one of the best tracers to use because of it, the physics. It has an energy between 100 to 200 keV, which is ideal, and this is the energy to image in the best manner. It has a short half-life of 6 hours, so it does not remain, it practically goes out of the body in after 4 half-lives, that is 24 hours. And it is trapped by thyrocytes, just like iodine. However, it is not organified. So within half an hour, we get some information on what is happening in the thyroid. And it is ideal for assessing the size, shape, and nature of the gland, presence of the kind of nodules, which I'll come to. And the indications for basically for thyroid scan, if we look at American Thyroid Association guidelines 2015 and their guidelines as well, normally if any patient who presents with thyroid dysfunction has to undergo a TSH test. If the thyroid stimulating hormone is reduced or suppressed, then you have to get a thyroid scan, technetium thyroid scan, or iodine 131, or if available, iodine, preferably iodine 123 scan has to be done. But most of the time it is the technetium 99M, which is widely available in nuclear medicines department, and this is done basically to look for whether the gland is hyperfunctioning, and in that situation we will also have a role to play in treatment of the this disease, and also to differentiate basically from thyroiditis, because both the condition will present with suppressed TSH and increased T4, T3, and as a result of which the thyroiditis would not need any active treatment, while Graves would active treatment in sense that it would not need any anti-thyroid drugs. However, it may require certain anti-inflammatory drugs, and it would be self-limiting. On the other hand, in Graves' patient, either anti-thyroid drugs have to be started or patient has to be treated with radioiodine. Then in patients of congenital hypothyroidism, to look for ectopic thyroid, and to know if there is agenesis of thyroid, especially when sonography has not shown any area of uptake. And thyroid cancer follow-up, it is very useful investigation, as well as to know whether there is retrosternal extension of goiters, and in certain enzymic deficiency goiters, which is a kind of a rare indication. Now, this is what a normal thyroid scan looks like. it has uptake in thyroid which is more than the rest of the areas, almost like 2 to 2.5 times the parotid uptake. And this is oropharyngeal uptake, and these are both the glands. So while reporting the scan, we would say the thyroid is of normal size, shape, at normal location. Then each lobe we report as both the lobes, left lobe shows uniform tracer uptake. Likewise, we'll say right lobe shows uniform tracer uptake and this is physiological phenomenon where isthmus, it is thin, it shows lesser uptake. So this is whole of the gland is showing physiological tracer uptake, and normal background uptake concentration is seen, normal salivary gland tracer concentration is seen. This is something that we report. There are no distinct hot or cold nodules. So then we say there is normal trapping of technetium pertechnetate in both the lobes of thyroid. On the other hand, we may have a scan like this, where, as you can see in the right lobe, there is a distinct area where there is lesser tracer uptake. These are known as cold nodules. And there is a distinct cold nodule in the right lobe. Now, 10 to 20% of these cold nodules can be malignant and would require FNAC to prove that they are malignant. There can be other causes for the same. So, nevertheless, to know or to assess the biology of the nodule, this is a very helpful imaging. On the other hand, we may find a hot area, a nodule, but this has to be correlated with the history of the patient. This, though it looks like autonomic functioning thyroid nodule, was not actually autonomic functioning thyroid nodule. This was an incidental detection of one of the studies that we were doing in PGI. At that time, we found that you can see that there was no salivary uptake here. These were the salivary studies, and incidentally, we did not find the right lobe uptake. This was a patient of unilateral thyroid agenesis. So we have to know the pertinent history in the context, and we have to correlate with the sonographic findings. And while assessing the nodules, it is always good to do perfusion imaging to see how well perfused these nodules are. Malignant nodules tend to become much higher, to be higher perfused, but later on we'll have cold areas. Okay. Now this is another. Okay. So this is another technetium thyroid scan showing a distinct cold area in the right lobe, and this is not technetium thyroid scan. This is iodine 131 scan, and see the difference. This is iodine 131 scan showing a right lobe autonomic functioning thyroid nodule. I will be coming to the distinction between the two scans, which is many a times kept in DM endo and even MCH endo exams, whether clinicians are able to distinguish that they are looking at iodine scan or they are looking at technetium scan. The iodine 131 is not a good isotope to image because of the higher energy of 364 keV, as a result of which this does not come under the ideal energy of 100 to 200 keV, where our instrumentation behaves best and gives us the best possible image. And that is why we are not able to discern the edges of the body, and we have to use a lot of markers to tell that this is the chin. And SSN means suprasternal notch. So suprasternal notch is out here. So between chin and suprasternal notch is on the right side of the midline, we are seeing a nodule that is concentrating iodine 131. So this was the hot nodule or right lobe AFTN. Now this is another technetium thyroid scan showing long-standing grains that has developed nodular tissue. And again, you can see there are markers. We use a lot of markers. This is a marker for suprasternal notch. So we would know that the retrosternal extension is not there. But as compared to the normal technetium thyroid scan, this scan is showing a lot of uptake in the gland, but our background activity is not seen, and salivary gland activity is not seen. If you look at this, there's a normal background uptake, normal salivary gland uptake, and pharyngeal uptake. But here we don't see that. That is because there is increased trapping in this gland. And if we look at the iodine 131 scan of the same patient, the 2-hour uptake is 51%, and 24-hour uptake, which should be around 20-25%, is 70%, which means that this gland is hyperfunctioning. And it is typical of here hyperfunctioning gland, which may be amenable to radioiodine treatment. Especially these patients many of these patients are sent once their free T4 is normalized or TSH remains suppressed, and radioiodine is a very effective treatment for such patients. And this is how we calculate the uptakes. If you see, this is the uptake probe, and you can see that this is placed here above the patient, and uptakes are calculated. This has got the crystal, which takes the counts from the thyroid, which are emanating from the thyroid gland. And this is another patient of Graves. You can see hyperfunctioning. Both the glands are of normal shape, but here they are of increased size, and there is intense activity. And again, uptake is markedly raised, 53% uptake, which should be 25%, 20-25% at 24 hours. And 2 hours uptake should be around 5 to 10% at the most, 15%. But here we can see that 2-hour uptake is 22%, which is again much more. Now, this is these two uptakes, and these are both radioiodine scans and are showing a different kind of uptake. 2-hour uptake is much more in this as compared to this gland. That is, this is known as high turnover gland, as compared to 24-hour uptake, where 2-hour uptake is more. Such glands will require much higher dose for treatment because the radioiodine is not staying in them; it is going out in much faster manner as compared to this gland. That is known as iodine 131 turnover. This is another technetium thyroid scan showing of a large multinodular goiter, showing multiple areas. There are hot areas as well as cold areas, and this scan finding is typical of multinodular goiter. Most of the time, multinodular goiter would not require a technetium thyroid scan. This is a clinical diagnosis. MNG is there, FNA is proven it is MNG, and multi-site FNA has proven that there is benign. It is benign. Then probably a surgery or any other treatment would be required, whatever is chosen for the patient. And but when does iodine scan have a role? Iodine scan would have a role when particularly when we want to know. And in a few more slides, after a few more slides, I will show you which scans, how iodine scans also, or how where technetium scan helps in MNG when we have when we directly compare the findings of technetium scan with the sonography to know which nodule to be biopsied or which nodule to be FNAB. To be done in which nodule. This is another multinodular goiter showing hot areas interspersed with cold areas. These findings are typical of multinodular MNG, and many a times they are much more increased. They show much more increased trapping than surrounding tissue, and they are toxic multinodular goiters. Iodine 131 is ideal treatment for them, and they require much higher dose and multiple treatments. Now, this is just to show that many a times the scan of FDG PET, this is F18 FDG PET scan that has been done for some reason, some abdominal malignancy, abdominal tumors or abdominal lymphadenopathy is there, but there is an incidental uptake here in the thyroid. These are known as incidentalomas, and these are very important in these days, especially with the advent and widespread use of FDG PET. We do see many times incidentalomas are discovered, just like they are discovered during ultrasound, which has been done for some other purpose. And meta-analysis have shown that malignancy rates in incidentaloma can be up to 20%. And not only that, but as a clinician, you should ask the nuclear medicine physician that what is the SUV max of this? And a threshold value of more than 3.3 would point out that there is some problem out here. Now, focal thyroid incidentalomas, when they underwent histopathological evaluation, the pooled risk of malignancy was found to be almost like 36.2%. So the range is from 20 to 36.2%. That is the third Trigalia. All of these are meta-analysis and study in widespread, large number of patients. So the bottom line is that incidentalomas cannot be just left out. We have to explore them and to with ultrasound guided FNA or other modalities to see if there is a lurking malignancy. You cannot just leave them like that. So now this is another scan, which of this iodine scan, which is showing intense tracer uptake in the right lobe. This was the patient of autonomic functioning thyroid nodule on the right side, and this patient, when after a few months, when the scan was repeated, at this time the patient's TSH was suppressed, but this patient had undergone radioiodine therapy. TSH was suppressed, but free T4 was normal. Somehow, resident had ordered for an iodine scan, and this was found that the iodine, the nodule had completely degenerated, and TSH per se takes time to rise. So there is no haste for that, and one should not get scan done for this purpose. And we should wait for TSH to rise. As long as FT4 has normalized, we have done our job, and nature will take its own course. Now, this is another similar kind of thing. The person with right, and this one is not iodine scan. This is technetium thyroid scan, and it is showing right lobe autonomic functioning thyroid nodule. And this was this later on. Sorry, this is a iodine scan, and this is showing right lobe autonomic functioning thyroid nodule. And this which had uptake of 59.62%, and in then technetium thyroid, this is technetium thyroid scan, which had this right lobe autonomic functioning thyroid nodule, and after treatment with 10.9 millicuries, we had repeated a scan after 7 months, and you can see that once the autonomic functioning thyroid nodule degenerates or is ablated by the radioiodine, normal thyroid lobes, both of these take up function. This is just to show that how biologically important information is attained from the scan, that and is also the success of the treatment. You don't need to treat this patient again, despite the fact that TSH is suppressed and T4 is normal. Now, one thing we have to remember that iodine 131 scan shows bilateral breast uptake, and these are lactating glands, mammary glands. Even after weaning, the lactating mammary glands can show substantial iodine uptake, and we have to be cautious. We should give enough time for these tissues to involute. Otherwise, there will be unnecessary iodine exposure to these breast tissues. Now, this is another iodine scan showing bilateral increased trapping in both the lobes of thyroid, typical of Graves. Another one with enlarged gland, this is typical Graves disease, hyperfunctioning Graves gland. And another one out here, these are two different patients. And these kind of scans you should be very much familiar with. This is something that endocrinologists and my endosurgery police see day in and day out. Now this is iodine scan, and if you compare it with the technetium scan, even if there is increased trapping, sometimes edges may be seen, or but in iodine scan you would never see any edges. You have to keep markers to know where the suprasternal notch is, where the chin is, and so on. I'm not going into details of this case, but this was a classic case of Graves' disease, and patient went and got an ultrasound done outside, and ultrasound showed a nodule in the posterior lobe of thyroid. We did a FDG PET-CT, and we saw a focus in the gland. In the posterior lobe of the thyroid, and this focus in the posterior lobe of thyroid eventually turned out to be malignancy. So we have to be very careful when we are treating these patients. A sonographic correlation is required. There should not be any nodules, and it is not uncommon for nodules to be there in long-standing goiters. And if these nodules are having malignancy, then the management changes, because you are not going to treat them with radioiodine. You are going to, these patients are going to get operated upon. And FNAC of this patient was indeed, this was a patient of Graves' disease. FNAC was Bethesda 5, and because of the Graves, ultrasound guided FNA was done, and finally patient underwent total thyroidectomy. Now this is another patient of multinodular goiter in MNG with, as compared to this is the nodule that should be FNA. As you can see, the CT also is pointing out on the left side, and this left-sided nodule is having hypofunction. Therefore, this is the area to be biopsied to rule out any malignant disease. And this kind of picture. This is F18 FDG PET scan that was done for that was done for urinary tract abnormality reason, and there is incidental uptake of the FDG in both the lobes of thyroid in a uniform FDG uptake, and this is something that is known as is a typical of thyroiditis, and has to be evaluated thereof. Just the patient has to be worked up in terms of thyroiditis. This is not a malignancy like picture. Then one important aspect is, while doing technetium thyroid scan, we always tell the patients to drink water, because many a times swallowed saliva can be seen in esophagus, as you can see here in the food pipe. So once we take a repeat few after swallowing, after giving water, then this activity will diminish or will completely fade away. So this is an important maneuver that we do in the scans. Then this is a technetium thyroid scan, a typical picture of thyroiditis, a patient who is presented with suppressed TSH, and you can see there is no thyroid lobe seen, no activity seen in thyroid bed, and this is self-limiting. After 3 months of time, we will re-evaluate the patient with TSH and other investigations. But right now, patient would not need any active anti-thyroid medication, only symptomatic treatment, maybe beta blockers, and if at all, if there is a lot of tachycardia, otherwise simply because if there is pain, anti-inflammatory agents can be given. Now I call this technetium trap. This patient was referred to me for for ablation of the gland. Now, and this he had the TSH was markedly raised, and also had the sibling also had a similar thyroid problem. Now we have to see this in conjunction with pertinent history. Here the antimicrosomal antibody was also raised. So we did a perchlorate discharge test, and you can see perchlorate discharge test was positive. Total reduction in neck uptake was 59.5%, which is so high, and this patient had organification defect. It would have been not a correct thing to treat this patient with radioiodine and ablate the gland. These things have to be taken very cautiously, and in pertinent clinical history and other biochemical findings have to be seen. Especially problem occurs when they are simultaneously taking eltroxin and anti-thyroid drugs. The thyroid profile can be haywire. It is better to stop all thyroid medication, repeat a thyroid biochemical thyroid test after 3 months, and then see and take a decision for ablation, because you can't reverse ablation. Once you have ablated the gland, the patient will be hypothyroid eventually. This is toxic multinodular goiter. Again, some hot and cold areas, just as I had seen. And the mechanism that this tumor represents persistent growth of progeny of one cell that has somehow escaped the mechanism which maintains the normal cell division of thyroid, which happens once in 8.5 years. And this is another toxic multinodular goiter, and this one is having also increased trapping. From my friend, courtesy of friend, he has given this was the specimen that was taken out, and you can see the nodules and correlated with them. This patient had undergone surgery. Then this is what an iodine 123 scan looks like. This is not done in our department. This is a book picture. And iodine 133 scan is ideal because it has energy between 100 and 200 keV, and it will also show organification. And so we will have both the information on trapping as well as organification if we do early and delayed scans. And patient will not in radioactive iodine scans, iodine 131 scan, patient has to visit twice. We have to take 24-hour scan or 24-hour uptake. Unlike that, iodine 123 scans, patient does not visit twice. We can do the scanning after 5 to 6 hours and get both the information. So from that aspect, it is preferable, but it is not. It is expensive isotope, cyclotron produced isotope, expensive and not easily available in India. Right now, people are not, I have not heard of anybody doing iodine 123 in our country. Now, you can see, look at this X-ray. The trachea is deviated to the right. So there is a structure out here which is pressing upon. And once we do the iodine scan, we see that there is a huge retrosternal extension, and the patient was presenting with dyspnea. And this is very important for surgeons because they will remove it. The patient will require surgical correction. Even if these glands may be functioning more, giving radioiodine should not be the correct thing to do most of the time, because they will once there is edema that sets in, it will lead to pressing upon of the neighboring structures. And you can see this is another different patient where both the lobes of thyroid are there, and there was a huge retrosternal extension below this. This patient was presented with dysphagia, and this is the surgeon's job now to remove it and bring about the relief in this patient. This is the scan I was talking about when we are talking of multinodular goiters, that which is the nodule which is to be biopsied. The nodule which is having hypofunction, there is no tracer uptake. This is the right nodule. This is the correct nodule to be biopsied to get the better yield of whether there is malignancy or not in this patient of multinodular goiter. There is a sonographic direct correlation with MNG, and this is one of the scans, indication of technetium scans. Then this is congenital hypothyroidism. You can see ectopic thyroid scan, ectopic tissue here, or lingual thyroid, and classic case of lingual thyroid. Another patient, but this was adult, slightly later presentation, 8-year-old female with ectopic thyroid, that was lingual thyroid that was visible. There is no normal thyroid present in this patient. So these are particularly important because they can harbor malignancy at a later date. So you need to give a suppressive treatment and suppress them, these kinds. Now coming to radioactive iodine as indicated in thyroid physiology, this was a radioiodine, in fact, was a savior at the time when atomic bomb was the Hiroshima and Nagasaki. That because it was a byproduct of that, and in early 1941, Hertz administered cyclotron produced iodine 131 and iodine 130 mixture as therapeutic dose to first human recipients as Massachusetts General Hospital, Harvard, to a patient with Graves' hyperthyroidism. And this was first successful treatment of humans with artificially produced radioactive material. And gradually 29 patients, series of 29 patients were published in JAMA way back in 1946. And then this article was a 5-year follow-up study of 29 patients and documented successful treatment of radioactive iodine for hyperthyroidism. And follow-up study formally launched the use of radioactive iodine as standard treatment for Graves. Now, so it was first successful radioisotope therapy was between 39 and 41. That was P32 for treatment of polycythemia vera. But Hertz and Roberts in 1942 published the first, as I've shown, the first treatment in Graves' disease. How does iodine 131 act? It acts by trapping and organification of iodine 131 takes place in the thyroid site. And it provides a unique opportunity for internal selective radiotherapy in context of metabolic radionuclide therapy with low dose to other organs. So this is by sodium NIS or sodium iodide importer mechanism. So it has a half-life of about 8 days and has both beta and gamma emission. So iodine 131 has both beta and gamma emission. The importance is that beta emission is there to kill the cell, to do the cell killing, and gamma emission or gamma radiations are there to image the cell. So that is the gland. So normally we have to do scan after 24 to 48 hours, unlike technetium scan, which is done only half an hour after administration. Iodine 123, I have already told, it is expensive, not available, but has a 100-minute half-life, and same day scanning can be done. And iodine has been used for benign diseases like Graves, toxic multinodular goiter, and it leads to long-standing reduction in thyroid function and volume, and is aptly termed as unbloody thyroid surgery. Now, beta particles cause damage to thyroid, cause local inflammation and fibrosis, and reduction of synthetic capacity of thyroid gland. This is the mechanism of action of I-131. And for this therapy to be effective, thyroid tissue must accumulate and retain iodine long enough for adequate radiation to be delivered. Now, this is absolutely contraindicated in pregnancy and lactation, and other causes of other causes of suppressed TSH, like subacute thyroiditis and postpartum thyroiditis. Though giving radioiodine, whether for benign or for malignant condition, there are dosimetric approaches or empirical treatment. Either of them have not proven to be superior in many studies, and basically, regardless of the method, dose selection, routine uptake studies will be helpful to confirm that the gland is hyperfunctioning. Those who do not have uptake study, they can at least do technetium scan to look for that. So basically, factors that would affect would be the gland size, maximal uptake, and biological half-life of the tracer. And what we want to deliver is about 80 to 200 microcurie per gram of thyroid tissue. And assuming our biological half-life to 4 to 6 days will deliver about 50 to 100 days to thyroid. Higher doses may be required for retreatment, especially after 3 to 6 months after initial treatment. And previous treatment failure does not lessen the chances of successful retreatment. But dosimetric approach or empirical approach, the outcome is not much different. So it comes in form of radioiodine, comes in form of capsules or liquid formulation. Liquid formulation requires extra measures, but they are equivalent in efficiency. Now, coming to the thyroid cancer treatment, now, especially the ATA 2015, if we look at that, many of the indications have been cut down in this ATA, and due to which what happened was there was a lot of controversies, consensus, and there was a joint statement issued in thyroid. Basically, it was the representatives of all of these bodies, that is a ATA, European Association, Society of Nuclear Medicine India, and European Thyroid Association. They got together to basically to formalize the dialogue and activities between the and discuss the indication for iodine 131 treatment. And they came up with what is known as Martinique principles. And these 8 or 9 Martinique principles are important from the aspect that advancing our understanding of optimal thyroid cancer requires commitment by clinician, researchers, patient, and organization to engage in proactive, purposeful, and inclusive interdisciplinary cooperation. Goal of I-131 therapy should be characterized as remnant ablation, adjuvant therapy, or treatment of knowing disease. Our institution, there is a bias. We get a lot of patients who have already got metastatic disease. So we know that these patients will undergo total thyroidectomy, then they will be treated with radioiodine anyways. But we have to differentiate between what is remnant ablation and what is adjuvant ablation, adjuvant treatment. Remnant ablation is when the disease is localized to the thyroid gland, while adjuvant treatment would be given with an intent also to kill the micrometastasis, which we cannot see based on the pathology that is showing either aggressive pathology or there is extrathyroidal extension, and etc. Now, assessment of post-operative post-operative disease status is required to optimize proper patient selection for I-131 treatment, whether patient undergoes remnant ablation or adjuvant. Many a times in iodine-131 scan, we may see incidental uptake in metastatic site or in bilateral lung uptake. So for that reason, so the post-operative disease status evaluation should be standardized and integrated into routine clinical care. And optimum patient selection for adjuvant therapy requires consideration and evaluation of multiple factors beyond post-op disease, and risk stratification is required, because I will come to that risk stratification part that is very important in the later part of this presentation. And then optimal administered activity for adjuvant therapy cannot be definitely determined from published literature. This has to be more of a multidisciplinary meeting. We have to decide how much treatment we are going to give to the patient, and also knowing which patients are iodine-131 refractory. A proper definition has to be set and to rigorously followed. Now, this very important article that appeared was a systemic study with whether differentiated thyroid cancer benefit from post-operative radioiodine therapy or not. That was a review literature and of past decade. This was by Warburg et al. And they they included 770 studies they had selected, out of which finally they got 11 publications that they were as per their selection criteria. And each of these publications had more than 300 patients, some of them even having up to more than 11,000 patients, 11,800 patients, and including the SEER database was also there. And the literature published in last decades offer data that support adjuvant post-operative. So this answers the question whether radioiodine therapy has to be given in these patients or not. So of differentiated thyroid cancer. So literature published in last decades offer data that support adjuvant post-operative radioiodine therapy in differentiated thyroid cancer with a tumor diameter exceeding 1 centimeter. Therefore, at least until randomized prospective studies, which is very difficult to do, but can be done, randomized prospective studies provide otherwise the prescription of adjuvant I-131 treatment to all differentiated thyroid cancer patients with the primary diameter of 1 centimeter remains a reasonable option. This is something that you can safely answer to colleagues. Now, recently, just appropriate use criteria for nuclear medicine in evaluation of treatment of differentiated thyroid cancers have come, and they identified 42 clinical indications for patients with differentiated thyroid cancer, and basically they are intended to represent most relevant issues regarding the use of nuclear medicine in diagnosis and management of differentiated cancers, with a higher appropriateness score implying that this should be done. And coming to the radioiodine aspect of it, you can see that ablation of remnant tissue, adjuvant iodine treatment, and regional and distant metastatic disease have a very high appropriateness score of 8, 8, or 9. Unlike this, where pregnant or lactating patients, this thing radioiodine should not be given. Residual thyroid tissue documented with radioiodine after total in pregnant, or again pregnant and lactating patients is absolutely contraindicated. It is not what they have written as radioiodine appropriate from their implication that this is not to be done. Now, when do we do post-operative radioiodine scan? After the operation, we wait for about 3 to 4 weeks and let the TSH rise. Once the TSH has risen to more than 30 microinternational units per ml, that is the time when we when we give iodine and do the scan. It is to determine the residual tissue, to know if there is any metastatic disease, and if we know that radioiodine is concentrating, we are more happy treating. Now, this is earlier we used to do 100 microcurie scans. That was the only place in India where 100 microcurie scan was done. But now we have shifted on to 1 millicurie scan, and we can see that the focal uptake of iodine is seen between the suprasternal notch and the chin, and this is the residual functioning tissue. based on this patient had metastatic cervical node, so would be treated with higher dose of radioiodine. And this is just from the historical perspective. This is known as whole body scanner, and this was earlier used to when we had rectilinear scanners. This was used to see the biodistribution of iodine in across the body, from head, this part representing the head, this part representing the toe, and wherever we would see the peak, we would know whether it is physiological or problematic. And then if we see a peak here, then we know that there is some problem out here, probably in bone or somewhere. So we'll tell the technical staff to image this part only. And here we know between the head and the stomach, we are seeing the peak here, which means this is in the thyroid bed, which is the remnant tissue which is to be ablated. Now, this is the first scan that has been done. It is showing the large dose scan, the diagnostic scan showing iodine uptake, multifocal iodine uptake. Patient, that is initial scan after follow-up following surgery. Then this is the follow-up scan after 6 months when we have done large dose scan, just to check if the remnant ablation or adjuvant therapy is successful or not. And we see there is no uptake in the thyroid bed. In the follow-up scan, there is no clinical evidence of tumor. The TG has normalized, no imaging evidence of tumor outside the thyroid bed. Thyroglobulin has normalized, the anti-thyroglobulin antibody is not raised. So what we are looking at is the functional aspect, the functional imaging, the structural aspect, ultrasound, then the biochemical aspect. So we need all three free, biochemically free, structurally free, functionally free, and undetectable serum thyroglobulin. So we can term that this patient is right now disease controlled. We put them on naproxen suppression for a few years, say 2 to 3 years, and ensure that TSH is 0.1 or less than 0.1, because THS is stimulant for any residual cells. So patient has to be kept on naproxen suppression for this period of time, so the disease doesn't come back, and follow them up on naproxen for along with ultrasonography. So whatever along with ultrasonography and serum thyroglobulin. So if serum thyroglobulin is going to miss some case, problematic case, then ultrasound will pick up the nodes in the neck, which is normally most common site of the recurrence. So this is just to show an example. 19.52% uptake was there after surgery, and we did ultrasound. We found that about 1.7 to 1 into 0.9 centimeter tissue was there, and we treated this patient with high dose radioiodine therapy. And this is the post-therapy scan. We always do post-therapy scan to see any incidental uptake in other areas other than the outside the thyroid bed. And this is the follow-up LT scan. Again, some focus was seen, but look at the uptake had fallen to 0.07%, and stimulated thyroglobulin was just 9.1. And again, correlating with ultrasound, we did not find any tissue. Here's a patient who have now gone back and is on naproxen and being followed up on naproxen. Now coming to another patient, normally after total thyroidectomy in a patient, I would not expect a TG of more than, don't expect a TG of more than 300. And this was a patient. And another aspect, if you can see, the anterior image focus is much lesser hot than the posterior image focus. So we knew that there is disease problem somewhere else, and just a remnant will not have a TG more than 300. Outside TG repeat was also, as far as I remember, in thousands or something. So that cannot account for such cannot be accounted for by such a small so much less milligram of tissue. So when we did a PET scan, we found that there was a cervical vertebral involvement here, and patient was treated with high dose radioiodine. And one aspect was that this was a functioning metastasis. These are functioning metastases. So many a times we cannot have TSH more than 30 in many of these patients because they are functioning metastases. TSH, many times we have treated with TSH 10, 15, especially in multiple metastatic areas. Here there was another metastasis here in the right side, as I'll show you in the next slide. So this was the repeat scan. We can see both the cervical vertebra is now showing intense uptake. but the residual tissue may not be there. But here we can see there was some linear uptake here. Such intense linear uptakes should be ruled out as contamination. We changed the clothes of the patient, washed, and after changing the clothes, we found that this is gone. This was basically because patient was sleeping on this side with the saliva drooling and dripping on the clothes of the patient, and the saliva being having radioactive iodine contaminated the clothes of the patient and was seen in the scan. So we have to be very careful with such aspects. Then again, patient was treated with 254 millicuries, and you can see the metastasis in the pelvis and the cervical vertebra both are concentrating. This is another papillary thyroid carcinoma with aggressive variant. This patient had wiped his saliva and with the handkerchief and kept the handkerchief in the pocket. And when we changed the clothes and repeated the scan, we found that there is no uptake, abnormal uptake we are seeing in the pelvic area. Only the residual tissue is there. Though it was aggressive variant, such kind of uptakes, we have to be very careful. We have to rule out contamination. This is the post-wash scan of the patient. Then this was a patient who had presented with a cold nodule on sonographically in serial few months duration. The cold nodule had grown from 29 millimeter to 38 millimeter in the largest dimension, and TSH had also shown slight fall, but this cold nodule remained like this. We did a FDG PET scan, and we saw intense uptake here in PET, as you can see, with a SUV max of 26.62, and this was the patient of CA thyroid, underwent total thyroidectomy. This followed by iodine 131 scan uptake, which showed this you can see residual uptake. Now residual uptake of 1.92% with multifocal uptake in neck. The patient was treated with higher dose of radioiodine. And then this is another patient, follicular variant of Papsia thyroid, limited disease. Now, what you would see is that diagnostic scan that was done on 18th October showed a focal uptake. However, when we did a post-therapy scan after treating on 14th November, when we did a post-therapy scan, we do not see any uptake in the neck. Please be aware of this pattern. This is known as thyroid stunning. When we had done a diagnostic scan with 4 millicuries in this patient, 4.18 millicuries, at this time the gland had taken up the whatever residual tissue they had taken up the iodine, and the right time to treat this patient would have been within 1 or 2 days, as far as possible, definitely within 2 or 3 days, but not after 15 days. So as a result of which the what is known as thyroid stunning happened. The more dose that we had given, higher dose that we had given, never entered the thyroid bed at all. We have to be very careful for thyroid stunning. We should plan scan and treatment in such a manner that they are as close as possible. Then ablation with low dose of radioiodine and thyrotropin alpha in thyroid cancers. Strategies of radioiodine ablation in low risk. These are two very important NEJM articles, and these were randomized controlled trials involving 752 and 438 patients, where 30 millicuries was shown to be as effective as 100 millicuries in reducing thyroglobulin to a very low level and eliminating residual thyroid tissue as seen on ultrasonography. And 21 to 59% of these patients in these two studies had already met the goal of low thyroglobulin level after total thyroidectomy alone. A recent 10-year follow-up study showed that use of I-131 did not prolong overall disease-free survival in low-risk patients. That was in JCM 2012. However, omission of radioiodine therapy also precludes post-treatment whole-body scan, which can disclose unsuspected or distant metastatic disease in 3% of these patients. That we have to be very careful about. Then whether there is any prognostic significance of successful ablation with radioiodine, this has been clearly shown, where this successful versus unsuccessful ablation, disease-free survival was much better. And similarly, thyroid cancer-related survival was 93% versus 78% after 10 years. So ablation is the thing. And this is one of the most quoted studies of Mazafri, very long-term data of 40 years, and which showed that this is no medical therapy. This is thyroid hormone only therapy, and this one is iodine 131 ablation is also added. So you can see that there is clear-cut, distinct survival advantage. So normally earlier they used to say 2 negative annual whole body scans have good predictive value for lack of future recurrence. Normally we are just sticking on to one scan and doing this. Most important is the post-operative risk stratification of differentiated thyroid cancer patients. So this requires pre-risk surgical risk stratification, post-operative risk stratification, intraoperative risk stratification, and post-surgical risk stratification. And this is a teamwork. Nobody individually can do. And conventionally, in most cancer risk stratification system, the classification of patient is based on information obtained from pathologic report and simultaneous imaging finding. However, risk assessment should be an ongoing process that uses new data obtained during the follow-up to alter the initial risk. And for that, we need peroperative findings, final histopathology, molecular biology, post-operative serum thyroglobulin, and that is the pre-radioiodine treatment serum thyroglobulin, and pre and post-operative ultrasound and other cross-sectional imaging. Now, this is just to show endoscopic axillary lobectomy or anterior cervical thyroidectomy, two approaches. What we always do is we discuss the findings with our surgeons, that what was the intraoperative, that is most important. Pathology report alone may not be sufficient to determine the completeness of surgical resection, because therefore we must talk to the surgeon. This is from my friend Dr. Tesh Agarwal. This is the specimen they put on the table, and along with a note, you can see this is another specimen. Their nodal dissection has not been done. So we are interested in primary tumor size, vascular invasion, extrathyroidal extension, lymph node metastasis, perinodal extension, and then various aggressive variants that we have seen, insular, hobnail, tall cell columnar, etc. Now, or there may be low risk pathological variants. And I'm not going into details of pathology. These were just the slides for the completion's sake, that the medullary anaplastic, follicular, PAPCAs, tall cell variant. But nowadays, we are also looking into the biology of the tumor, the BRAF mutation, the RAS, RET-PTC, and MUC1. So the things are changing in future scenario. We do expect that BRAF mutations and will be much more done. In our center, we tested the prevalence of BRAF mutation in thyroid cancer patients in Indian subcontinent with 140 thyroid specimens, and found about 61% conventional PTCs and 11.7% FPPCTs had this BRAF mutation, but none of the follicular adenomas or follicular thyroid carcinomas or medullary thyroid cancers and benign hyperplasia showed this BRAF mutation. So again, ultrasound is important to exclude clinically important lymph nodes. Precise cutoff value and exact timing is not well defined. Institutional calibration is required for the serum thyroglobulin. This has to be really standardized in each and every lab, and has to be done accordingly. But ultrasound and serum thyroglobulin are to be used for follow-up, and cross-sectional imaging or PET-CT may be required, especially when there is distant metastasis as presentation or aggressive pathology or tennis. I'm just showing you one case of a patient who presented with seizures, and following this, we did patient was found to have following a brain surgery, she was found to have a brain mets that was from PAPCA thyroid and differentiated thyroid cancers. It was removed. It turned out to be follicular carcinoma of thyroid, and review of pathology at our institute showed it to be follicular variant of PAPCA thyroid, and she had multiple mets in the brain, in the lung, even in the kidney there were mets. And one good thing about that case was that FDG PET, at that time we used to have PET only imaging, and FDG PET did not have any hypermetabolic area. And as you can see, after about receiving a cumulative dose of 1200 millicuries, this patient had recovered completely, and follow-up PET was negative, and she was doing absolutely fine. And this is another patient in whom we had seen multiple metastases. But in all these patients, we tend to do PET scan as well, because positivity in PET implies poorer prognosis. Now, this is the first RAI scan of this another patient, 25-year-old male with differentiated PCT and metastasis to pretracheal node. And you can see again follow-up RAI scan, superior mediastinal nodes showed multiple lesions, bilateral lungs and serial I-131 scan with PET scan showing no lesion. Again, a good prognostic sign. But this patient is having, you can see metastasis, multiple metastasis, and there's a rib mets out here, and she had mets in the retroorbital area, and PET scans, serial PET scans were showing intense uptake in the metastatic areas, including the right rib and the pelvic metastasis. You can see here the pelvic metastasis and the right rib. And this patient, even after 995 millicurie of I-131, was showing progression. And this is another patient having positive PET scan. Now, when we did a RAI scan, we did, this patient had poorly differentiated foci. He had received 399 millicurie twice. When a follow-up RAI scan only showed a small focus, the patient was actually quite dyspneic. And when we did a PET scan of this patient, we saw there was a lot of inoperable mass in retrosternal, below the sternum in these areas. And though the TG was again not much raised, it was just 6.3 and 3.2. And I'm talking of stimulated TG. Now, this is another patient, again, TG more than 250, having multiple mets. What we have seen is that, both iodine as well as FDG, both of these concentrate in the same metastatic, concentrate in the same metastatic areas. So there can be both concordant as well as discordant lesions on the same scan. A true flip-flop may not be required. And that is why many studies came up. And these are, I'm talking from the JCM. Cells of high-grade tumor usually lose some of their differential functions, and such as uptake of iodine, and therefore are likely to be missed on diagnostic whole body and post-treatment scans. Metastatic lesion may be both iodine and F18 FDG, and traditional concept of flip-flop may not always be true. FDG scan are more likely to reveal foci of uptake in location outside thyroid bed, and this could be attributed to varying biology of metastasis compared to primary tumor of thyroid. And they also provide prognosis, because these are the areas which are going to become problematic in future. And in multivariate analysis, normally if FDG PET has been used only for tennis lesion, that is thyroglobulin elevated non-iodine supporter lesion, concentrating lesion, but with the sensitivity of 47 to 100%. But in multivariate analysis, among multiple prognostic factors, including age, initial stage, histology, etc., it was found that only age and FDG PET results continue to be strong predictors of survival. Furthermore, more active lesion and more number of lesions of FDG PET scanning inversely correlated with the survival. This is very important finding that was done. Another patient with having multiple metastases, and you can see that there was bone scan, and there was multiple. This is the same patient I showed. Why I showed this scan was that we had done lutetium dotatate therapy to her to provide palliative intent when there was no other option left. And you can see from the appropriate use criteria that evaluation of SSTR expression for RAI refractory thyroid may be appropriate, and this is something that's being studied. And this was a scan of gallium dotatate that was showing uptake in a rib lesion as well as in the retroorbital areas on the right side, and in the pelvic areas. So we treated her with iodine. This is another patient with a resistant kind of a skull mets, and it had been there even after cumulative dose of more than 1 curie. We don't go beyond 1 curie. There was no other option left, and we did this gallium dotatate scan, and we subjected this patient to lutetium dotatate therapy with some with palliative intent, of course, and some improvement. Then I'm going to skip this case for now. It is a similar kind of case. So lutetium dotatate treatment for documented SSTR expression in RAI refractory thyroid cancer may be appropriate, and this is something that needs further evaluation. Now, risk estimation is required, but when we are talking of risk of thyroid cancer, risk is risk for death as well as risk of recurrence. And in thyroid cancer, risk of recurrence does not always parallel the risk of death. These patients survive for quite a long time, even with extensive metastasis. So, particularly in young patient and high recurrence risk, low death risk may be there. So similar adjuvant therapy may decrease the similarly adjuvant therapy may decrease the risk of recurrence without impacting the risk of death. Therefore, both disease-specific death and recurrence risk have to be separately determined for these patients. There are multiple guidelines for this. We know MAs, AGs, these criteria, that is for risk of mortality, even the MESIS score that we may be using in clinical groups to differentiate between high risk and low risk patient. But the problem with the guidelines is that they provide conflicting recommendations. So, but most predictive factor, as of now we know, is age, presence of distant metastasis, and extent of tumor. And we use the 8th edition. This is what I was telling. We have to talk to the surgeon. Surgeon will tell that this was T4B. There was inoperable extrathyroidal extension. These two treatment, and in this these two patients will require different kind of approach for treatment when we are giving radioiodine. And then definite advantage of TNM system is there that we follow, and it is best for separating the group of patients with distinctly different survival curves. That is why we use TNM, and that is why TNM is widely used. Okay. So for risk of recurrence, both ATA and ETA have developed practically similar kind of guidelines, naming them slightly differently, and tumor-related parameters integrated with each other clinical features, including the results of post-ablative whole body scan and serum TG measurement. These are, you can go through them in the literature, that ETA is what characterizes very low risk and high risk category, or ATA as characterize a similar kind of thing as low risk, intermediate risk, and high risk category. The risk does not remain same always. And one important thing is that in this stratification, you are using the iodine 131 uptake and scan findings as well. So functional imaging comes into play when we are risk stratifying, and the risk is a dynamic risk stratification. It does not remain the same. Today, a patient is at intermediate risk. They may become at low risk at a later date when you reevaluate them after 2 or 3 years after giving radioiodine therapy, or they may become high risk if there are distant metastases that were not there earlier. So they have to be continually re-stratified. This is what is known as dynamic risk stratification. This is just an iodine scan showing unilateral breast uptake because of the preferential lactation of the child from one breast. We have to be careful of that. This is what I was talking about. Ongoing risk stratification or dynamic risk stratification. It better defines patient risk on the basis of results and initial treatment results, conceptually based on continuous integration of initial risk stratification with follow-up clinical, laboratory, and radiological data. Both ATA and ETA are good starting points for initial decision making. However, they are less accurate in predicting long-term outcome in differentiated thyroid cancer with low positive predictive value. Many patients initially classified as intermediate or high risk were found to be in complete remission in dynamic risk stratification. For example, if you see that case, Ishwar, who had multiple brain metastasis, and in post after one query, she has completely recovered and she comes into the low risk category. So, what are the clinical implications? Once the risk of recurrence and death are established for an individual patient, clinician can then plan an initial treatment and follow-up plan. That whether adjuvant treatment is to be given, or whether EBRT is to be given along with it, and what is the level of suppression, and for how long the TSH suppression has to be there. So then in our study group, we had also seen expression of PSMA in metastatic differentiated thyroid cancers, and we are exploring it further. It was just in about 30 lesions in 32 lesions in 10 patients, and we found that iodine scan the PET scan, and this is the PSMA scan. Now, PSMA is supposed to be prostate-specific membrane antigen, but it appears in highly vascular areas. It shows its expression because of vascular increased endothelial expression. So we had demonstrated this, and we are now further exploring this into this. Another patient showing uptake here in the pituitary fossa, and this turned out to be metastasis from this patient had presented with diplopia. As you can see the location of the lesion, and this turned out to be radioiodine. It was meningioma, reported as meningioma on CT, and MRI also agreed that it is a meningioma. It turned out to be metastasis of differentiated thyroid cancer. Another presentation where presentation with right parotid tumor, it turned out to be metastatic differentiated thyroid cancer. We after total thyroidectomy, the therapy was given. Then this was another patient showing multiple event metastasis along with the lung mets. We first thought it is lung mets, but pathology, patient got a pathology done at local place. It was bronchoalveolar carcinoma. It was concentrated iodine. Sometimes such tumors, if they have NIS expression or by other mechanisms, they can concentrate iodine. This was a patient which was a classic. We have lost this patient just because this patient did not take any altroxin suppression for 20 years. For 2 decades, he did not take any altroxin suppression, presented with lumbar metastasis. And then all we could do was palliative treatment, and there was nothing more we could do. This patient had both adrenal and renal metastasis, histopathologically proven. And this patient, even after 1 QD of treatment, then slowly and steadily the patient's condition deteriorated. Then again, this is multiple methods. We can follow the guidelines, but not blindly. We develop your own institution-based protocol on based on your evidence practice. We have our own protocol. I'm not going into the details of the protocol because of the paucity of time, but I will just show 1 or 2. These are metastatic areas. This is one patient I wanted to show. This is excessive metastatic area. Here, patient could not even lie down properly. Sometimes you have to do scan in 2 phases. No harm in doing that. You can see this is a cut scan, but we have to make the patient comfortable. And these PET scans will play a very important role in prognosticating. And this is the patient here received multiple treatments. Then we'll skip this case, and again this is the one I had showed. Okay, so these are again these are multiple metastatic areas. This patient presented with lumbar metastasis. This patient presented with vertebral metastasis, and FDG PET was also simultaneously concentrating. We have to then do PET to see if in follow-up we are having the then another aspect is that many times lung metastasis may be there. If these lung metastases are negative on X-ray but positive on our scan, it means good prognosis. Nevertheless, we should do HRCT, and even if we have millimeter lesions to follow up, we'll have some structural response evaluation as well, which we must do in such patients. Then I think okay. In radioiodine refractory treatment, systemic therapy has been used. I am not going into details of that. I have already shown multiple, but just last few slides to show what we do here in Radiation Medicine Center and in other nuclear medicine departments. We are using the principle of time, distance, and shielding. We spend lesser time with the as far as possible with the activity. We maintain maximum distance, and we shield these radioactivities always shielded in thick containers. And these are, while administering radioactivity, if UMOD is used, you can see the paper out here. This is a negative suction pressure. So iodine is a volatile compound. So once it is released, there is a negative suction pressure that takes away all the vapors into the chamber. and that way the radiation dose to the staff is very much minimized. And we have portable ionization chamber, radiation-based survey meters to check for the radiation in these patients. And when their radiation is in permissible limit, we are able to discharge them from the ward. Not only that, but the radiation personnel are those who are handling radiation. They are also monitored so that they are not contaminated. Their radiation, they don't carry back radiation at home, which can be detrimental. So radioiodine therapy is unique since it requires attention to radiation safety procedure, necessitating hospitalization and isolation of patient in radiation ward. And patient is discharged when the atomic whole body retention of radioactivity is less than 550 megabecquerel. That is the ARB limit is ensured and established by patients monitoring using a portable ionization chamber-based survey meter. So does radioiodine treatment cause cancer? Multicentric retrospective cohort studies examined cancer mortality in 35,000 patients after 3 treatment modalities. I'm talking of hyperthyroidism here, but otherwise RAI otherwise also is not associated with excess total cancer death. Incidence of thyroid cancer in RAI treated patient over 27 period was not significant from general population. Then does radioiodine have adverse effect on genetic offsprings? It delivers about 0.01 to 0.03 grays to ovary, mostly from excreted iodine in bladder. No adverse outcome is seen in subsequent pregnancy. And but we tell the patient to avoid pregnancy for at least 6 months following therapy. Then what precaution does patient have to take after receiving iodine? It is the standard. We tell them to sleep alone for a few days, maintain social distance. Now this concept has come up after all this pandemic, but we have been doing this for these patients for who have taken radioiodine. We avoid contact with children and pregnant women, hydration, toilet, clothes. So thyroid cancer, with all its peculiarities, biologically and histological criteria, should be treated as any other cancer. Get rid of the tumor and do everything to avoid recurrence of treat meds as well and as long as you can. To summarize, radioiodine treatment has been used in patient management for more than 6 decades. In 50 and 60, it has even been used for treatment of congenital heart disease, refractory cardiac pain, and in cardiac failure in absence of better treatment. However, for thyroid disease, its use has increased, which can be attributed to safety and efficacy of this treatment, increased incidence, increased physician awareness, and acceptance by both patient and physicians. So it is definitely one of the few radiopharmaceuticals which potential curative effect contrast to other so-called radiotracers for diagnosis without any pharmacological effect. Unlike other therapies, radioiodine is unique since management of patient from time of administration of radioiodine till discharge requires the support of radiation safety officer to ensure radiation safety and hygiene practice in institution. It remains an effective tool to control benign and malignant thyroid disease with few and controllable side effects. So initial risk assessment can be used to guide management with regard to need for RAI ablation, degree of TSS suppression, and follow-up testing during first year of follow-up. Re-stratification of risk based on response to therapy can thereafter be used for long-term management, including follow-up testing protocol, modification of TSS suppression, and need for additional therapies. Thus, re-stratification and differentiated thyroid cancer is a dynamic process and can change during the lifetime of patient. Contemporary management demands an individualized approach based on initial and follow-up risk evaluation. Thank you so much for your kind attention, and sorry for exceeding the time. I hope some people are still there. And
No. So the only the fortunate ones are still there. So it's not that you exceeded the time. I think the topic was such and the details which you went into. I'm so happy that you actually started with the physiology of it rather than jumping into the diagnostic, because many times we skip the physiology part. We ourselves skips the physiology when we were planning these series, because physiology plays such an important role in the management of especially thyroid cancer, as the radioactive iodine is all based on physiology. Dr. Abhishek, your take.
Very exhaustive presentation, and virtually I think you have covered everything. Nothing is left. Now, one question from my side. How do you foresee the role of iodine 124 PET CT in management of thyroid cancers?
Actually, I was thinking of including I-124. I thought then by that time even I will go off to sleep. But anyway, so iodine-124 is a very important. It's been, see, whatever happens is whatever literature comes, most of the time it comes from the US, and US FDA has recently approved I-124. But long-term studies have shown that I-124 PET has definitely much more higher sensitivity than even post-therapy iodine 131 scan, which means that in post-therapy iodine 131 scan, we see many times we see additional areas, additional metastatic areas, but I-124 has even higher sensitivity than that, and iodine 134 PET. And another is the dosimetric approach will be, it is kind of the dosimetric approach redefined, because in PET we are going to actually define the dose that will be reached, that will be that each and every lesion will receive, or remnant will receive, and this is very important, going to play a very important beneficial role for the patient, and even in chalking out the treatment, even in prognosticating that what will happen to this patient.
So actually, Dr. Abhishek, that is why I had asked in the chat box about the cross-sectional imaging, because you and Dr. Gaurav can see 101 shades of yellow to brown when you report a nuclear scan, but for us it's just yellow and brown. It's not from yellow to brown. So that is why for us cross-sectional imaging matters, and that is why I was actually pointing towards FDG kind of iodine compound, which can help us in
Yes.
lesser mortals like us to see the thyroid scan. But I think you made the point well, that we don't use SPECT good enough or very routinely enough to use, and one of the reasons is that the thyroid anatomy is not all that tricky. That is why most of the times the surgeons are able to get away with doing a thyroid surgery, and only in the rare cases. And I'm sure actually Dr. Gaurav must have seen much worse thyroids than what we do in our clinical practices, especially the ones which are invading the paravertebral and the prevertebral spaces, because in our routine practice we don't see thyroids doing that bad actually, really. So that is one of those. I also wanted to ask about anaplastic thyroid. What is there actually any role of radioactive iodine? I know it's one of the worst.
You can give it if you want, but it is practically not our domain at all. Anaplastic will not express. We have only seen a very few, 2 or 3 cases of anaplastic in last 1 year. And I have seen 3 cases. If others, even if we combine, it will not even be 10.
So it is so poorly differentiated that it will not even take.
As a yes, poorly differentiated and anaplastic, I would segregate into 2 categories. Purely anaplastic are not the ones to be treated with iodine multitable. They are to be treated aggressively with radioiodine or radiotherapy or whatever you want to. But it will not survive. Your patient will not survive beyond few months. And the poorly differentiated ones are the ones we can still embark upon, and give radioiodine and see if there are some foci which are there, and they may still show some, but once some better prognosis than the anaplastic. But once anaplastic transformation of these cells take place, then we are left nowhere.
So poorly differentiated thyroid carcinomas are generally to be treated as a papillary carcinoma. If you go by
as an aggressive one, in sense that because if it is concentrating iodine, then go ahead, give 200 millicrease, 250 millicrease, and if again it is concentrating next time, treat them aggressively as far as possible. It is just the bystander effect that would probably help in these.
Okay, sir. I think Dr. Abhishek has answered most of your questions, and he was actually kind enough to take even the medical oncology questions. He talked about lenvatinib and sorafenib, and
when I was seeing the time, I skipped those slides also. As what because lenvatinib and sorafenib trial is also going on out here, and even darunafib for that matter. So these things are now
I know. So, but
beyond the scope of this talk.
Yeah. No, I agree, sir. So I would actually want to thank Dr. Gaurav that he took all the pain and he took this lecture for us at. We started at 8:45 and it's 10:10, and I am sure he is still willing to talk about it, and it shows the passion with which he does his work, which he excels in. That he can go on to talk about it. Is Dr. Geeta around? Hi, Dr. Geeta, is still there?
Yeah, I'm there.
Yeah. So, Dr. Geeta, I just wanted to mention that, we had 3 lectures on thyroid, and all of them were by such experts, which like Dr. Shipra in the pathology part and Dr. Gaurav. And I feel that it is also because of Dr. Abhishek and Dr. Anuj that we came across these people. I would not have approached Dr. Gaurav Malhotra by myself to take this lecture for us. We would have probably got stuck at the more familiar names that we know. But thanks to our extended team, which helps us to get these people. And thank you so much, Dr. Gaurav.
Thank
because of you, it is for the first time that I have got 4 requests that they want your PPT slides, and I have refused.
So go ahead, give them. That's no issue.
So this is a journey of discovery for us also, because we are discovering new people, and I think we get stuck in a stereotype because because there are certain names that are heard often, but I think we get stuck in a stereotype, but we realize real pearls are elsewhere. And we seem to be discovering them, and I think it is all for the benefit of students at large. And the thing is, it doesn't really worry me when we have 25 students watching this live, because you're going to be archived in our YouTube channel, and they will always go back and read it, because that is your legacy also. So I think both you and Dr. Abhishek, of course, he's the flag bearer of our nuclear medicine department, and I've done a great job, and I'm sure we'll have more opportunities to interact in the same manner.
Thank you. Thank you.
And with this lecture, we'll close the thyroid saga in the month of January, and we'll be moving to esophagus for the month of February. But before that, we have the World Cancer Day coming, and we have planned really something different this time. This time, I mean, for the first time, we started in June, so this is our first World Cancer Day. So what we are doing actually is getting the doyens of oncology, medical, radiation, and surgical with us, and we'll be posing to them 10 questions, 10 pertinent questions about surgical, medical, radiation, oncology futures in India, how they foresee it. These are the people who have seen how the last 10 years shaped out, and we want to ask them how the next 10 years are going to be, so that, if there is a surgical oncologist who wants to be a thoracic surgical oncologist, he or she can decide whether it's the right way to go or not. No pun intended. But the point is that we should talk about this more often, because this is how we should look into. Looking back is actually looking forward, by deciding what we have done before, is it the right way, and will we be moving in the same direction. And there's no point, there's no retraction in doing course correction, but you should know that course correction is going to be correct or not. Again, no pun intended. So with this, I invite you for our next next
you
class.
Must come, you must, because
yes.
Because I think these are people who have actually evolved over a period of time, because when you look back 20 years, there was hardly any oncology happening in our country, and today we are almost rubbing shoulders with the best in the world.
Yes,
and
absolutely true.
So we have to find a space where the access to optimum care is reaches out to the last person standing, because as of now it is still out of reach for most people. And as doyens or as people who have walked this journey, whether it is in the government sector or in the private sector, it is time for us to raise the bar and, get more and more people into the fold and see how we can reach out to more people. Whether it has to be a policy change, it has to be advocacy for all these people who are out there who don't have access to cancer care. How does private and government institutions start holding hands instead of looking at the other way? Because things are changing there also. Things are changing there because, about, say, when I was doing my post-graduate, I used to think Tata Memorial ke log na kuch alag hi honge. Matlab, they're out of bounds. You can't talk to them. वो हमारे बारे में क्या सोचते हैं कि हम उनके पर. Now I think that divide is slowly going down and the walls are breaking down. I think so. It's all we're in a good space. I think this is the time to ask these questions.
Okay, then we'll catch up next week with this.
Sure.
Okay. Thank you, Dr.
Okay, thank you so much for
Thank you so much. Thank you.
It was a pleasure interacting with all of you. This was great. Thank you so much.
Thank you.
And
Good night. Good night.